We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, AJIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Nikki, good to hear your voice.
Oh, thank you. You too, as always, Jess.
So, as always, we have a joke to start off today.
Oh, boy.
So, I probably haven't mentioned this, but I'm thinking of moving to Europe to study different types of bacteria.
Ooh, really?
Yeah, I figure the best place to begin would be Germany.
I get it. Germany. All their beer will kill it off anyway.
True. So, Nikki, we have some fantastic guests here with us today. First up, we'll be talking with Dr. Jingjing Shang about her research on influenza vaccination of home healthcare staff and the impact on patient hospitalizations. Dr. Shang is a professor and health services researcher at Columbia University School of Nursing. She received multiple federal grants to study infection prevention and control in home healthcare setting. She established critical evidence and demonstrated that infection is a significant but understudied issue in home healthcare. Her team conducted the first national survey of infection prevention and control in home healthcare and examined how agency policies were associated with infection outcomes using multiple longitudinal national data. She served in the American Cancer Society Peer Review Committee for Scholarships and has been a reviewer in CDC's Special Emphasis Panel in Infectious Diseases since 2015. Welcome, Dr. Shang. We're super excited to have you with us today.
I'm very happy to be here.
Awesome. So just to kick us off, can you tell us a little bit about what prompted this research?
Yes. Before that, I want to like to acknowledge my co-author of these manuscripts. I'm very fortunate to work with a wonderful team that includes Dr. Patricia Stone. She is a wonderful mentor and colleague, and Dr. Ashley Chaston, our senior project director, who ensures the success of the data collection, and Dr. Andy Dick and Dr. Jordan Harrison from RAND Corporation. We have a long history of collaboration with Andy's team. In our other collaboration, Dr. Monica Pogozaski Mazzara at Thomas Jefferson University. Monica, I hope I pronounced your last name correct. And I also want to thank our data manager, Dr. Gayani Parala, and Dr. Elizabeth Madigan, who help us to keep the research in the home health care context, and also all the home health agencies who participate in our study. So this manuscript is part of our large NINR-funded project. It's titled Infection Prevention in Home Health Care, shortened in-home. So in the in-home, we examine the infection prevention and control policies and procedures in home health care agency through a national survey and qualitative interviews. We also linked the survey data with multiple national data sets, including the CMS claims data and home healthcare OASIS data. So our survey was conducted between November 2018 through the December 2019, right before the COVID-19 pandemic. And the survey was aimed to assess the agency's the infection prevention control related infrastructure, policy, and procedure and staffing. So in this survey, we included 3 items specifically measuring the influenza vaccination policies and vaccination rates of the agency. So that is because of the current COVID-19 vaccination resistance, we thought this paper is really relevant, and so that prompted the publication of this paper.
In the paper, you mention something about the oldest adult, which is 85 and above, and also that the population at greatest risk for influenza-associated hospitalizations and deaths is the older population, specifically 85 and older. What's the demographic of the home health patient? I kind of assume that that is the oldest old adult and kind of further highlights the need for home health care worker vaccination.
Yeah, definitely. That is true. So the latest 2018 statistics show about a little bit over 1/4 of the home health care patients are more than 85 years old. So, and this number is actually higher than the all Medicare beneficiary, in which only a little bit over 10% are 65 years older. And another thing I want to point out is the home health care patients, over 80% of them have more than 3 chronic conditions, and over 43% of home health care patients have more than 5 chronic conditions. We all know all these chronic conditions can increase their risk for infection. So definitely this is the group of patients who have high risk for developing the serious flu complications.
Yeah, sounds like most of them are 65 or older with comorbidities. Definitely at high risk, yeah.
Yeah, you actually sort of started to answer my next question, which was in thinking about the fact that you had reported only about 26% of the agencies are requiring staff influenza vaccinations. And those are most likely to be the nonprofit or hospital-based agencies with better nurse staffing. I was surprised that more of the agencies didn't require vaccination, considering that this over 80% of these patients had greater than 3 comorbidities. Do you have any insights on why you think that might be, that they're not requiring the vaccination?
Yeah, we were also surprised by this low number of the flu vaccination mandate requirement of these agencies. So we regarding the relative higher rates among the hospital-based agencies, because the hospital-based agencies usually follow the policies and procedures of their parent institute. And the other research have found that hospital settings usually have a much higher flu vaccination rates. And hospitals are usually more likely to have flu vaccination mandates in place. So it's not surprising to see the hospital-based agencies are more likely to follow their parent the institute have the flu vaccination requirement for their staff.
Right.
Makes sense.
Yeah. And regarding the nonprofit agencies, multiple studies have found that actually the ownership of the agencies is not just ownership of the agency, ownership of all the healthcare institutes are associated with the quality of care. So usually it's nonprofit, like home health agency or hospitals have better quality of care, and they have a better policy, healthcare related policy that certainly include the infection prevention policies as well.
Yeah, and I want to talk about vaccine requirement and policies. So, interestingly, 71% of the agencies had staff vaccination rates that were higher than 75%, which seems good if only 26% had vaccination requirements. Do you think that the lack of vaccine requirement has to do with agencies' ability to maintain adequate staffing levels?
I do think that is probably is the main reason to for this low mandate rates. Our data cannot tease this out, but from our discussion with other some agencies, they do have the concern about if the mandate is implemented, they may lose their staff, especially during the pandemic. They're already studying losing the home health care staff for a lot of other reasons.
Yeah. in the paper, it also mentioned how the free and easy access is an incentive to staff to get vaccinated, which, makes total sense, right? But I was surprised that only about 50% of the agencies offered free on-site vaccination. Can you talk a little bit about how we can make it easier, or what some of the other reasons potentially why healthcare workers were not likely to receive the vaccine?
Certainly. Apparently, from our study, it shows the mandate, the agency mandate, will definitely increase the vaccination rates, and also the offering flu vaccination on-site and free can help boost the staff vaccination rates. But for the agency that offered on-site flu vaccinations, I think it's important, for example, to schedule the vaccination clinic multiple times and at convenient time to maximize the participation. And also, there's some other strategies which are emphasized, by the CDC, that can be applied to increase the vaccination rates. For example, it's important to get leadership support at the workplace, and placing the staff vaccination as the agency's priority, and setting up a goal to align with the policy. And also, I think designate a flu vaccination coordinator will also help increase the vaccination rates. And also allowing time, maybe a couple of hours for the staff member to receive the vaccination in their community can definitely increase the staff vaccination rate. It's very important to notice that a lot of home health care staff, they are home health care aides. And we also know from previous other study, the home health, the healthcare aides, home healthcare aides, they are usually the group of people who has the lowest vaccination rates. So it's important to give them time to free time to get flu vaccination in their community. And also, it's very important to offer some incentives for flu vaccination, and, for example, make the flu vaccination a part of their agency wellness program, and just offer some benefit for the staff to get flu vaccination.
Sure. Yeah, there's a lot of good ideas there.
Yeah.
So let's talk about some of the effects of vaccination, healthcare personnel vaccination. I have a twofold question for this. So you predict that just over 6,500 respiratory infection-related hospitalizations could be prevented yearly with a vaccinated home health staff. Do you have any prediction on deaths? And just to tack onto that, there's an 11.25% reduction, or 6,572 avoided hospital transfers as a result of staff influenza vaccination. That's huge. And you mentioned that the correlation was only statistically significant in for-profit agencies. So just to wrap up my twofold question there, do you have any prediction on how many deaths could be prevented, and why the correlation was only statistically significant in for-profit agencies?
Okay. Yes. So the reason why we want to predict how many hospitalization can be prevented, because we want to put a concrete number there to raise alarm to the audience, to the readers, regarding what we can save if all the agency implement the flu vaccination the mandate. So regarding the number of the prevented death, that was very good research question. Actually, we discussed this during our data analysis. We did not go into this direction because it is very difficult to attribute the respiratory infection to the death using the CMS claims data. That is data we are using for the analysis. But however, considering a large number of older adults, like approximately 75%, American older adults died from influenza-related complication during the 19 and 20 flu season. So we can definitely say increasing the home healthcare staff vaccination can definitely prevent death.
Fantastic. So switching gears just a little bit to talk a little bit more about the research piece, can you tell us a little bit more about OASIS, MBSF, MedPAR, and POS and how they were used in this study?
Sure. So so in addition to the survey we conduct, we obtained the longitudinal CMS data. The OASIS is the primary data we used here to capture the patient's individual characteristics. So OASIS is the CMS the mandate, required standardized the outcome assessment data, which is for all the home health care patients. The agency need to collect the OASIS data at the beginning of the when they enter the home health care agency, and then whenever their status changes, such as when they have transfer to the hospital, when they discharged from home, or if nothing happened, when they reach the 60 days time, another OASIS will be assessed. OASIS capture a lot of about demographic information, also on the patient's medical history, their physical and psychological condition, and also social support and their function capacity. All this information we used in our risk adjustment in our analysis. So that is the OASIS data. Another data we used here, which is the MedPAR data. MedPAR data is the Medicare beneficiary inpatient hospital final action stay record. So that includes the ICD code and the procedure code and corresponding to the dates of service. So MedPAR data is the primary data we use to capture the outcome, that is the respiratory infection associated hospitalization. So we use the MedPAR to capture our outcome variables, and also the MBSF is Medicare beneficiary summary files that provide additional the demographic and enrollment information. So those are the primary data we use in our study.
Okay, interesting. And while we're on data collection, paper says that out of 1,506 agencies surveyed, only about 36% responded. How do you think that affected data collection?
So certainly, we really want to have a higher response rate. But as you know, this is home health care is very hard to reach group. And compared to other study, I think our team has a relative very high response rate. So definitely, we consider the potential the response bias in our analysis. We compare the agency characteristics, the main characteristics between those who responded to our survey and those who did not. And we did not find the significant differences. And in addition, we also used we called the weighted measure to compensate the outcome. So those are the strategy we applied in order to increase the generalizability of our funding.
Okay, interesting. So last thing, can you tell us how you think that the influenza vaccination is correlated with COVID vaccination rates among these healthcare workers?
Yes. So as I said before, we think because our survey was conducted right before the COVID-19 pandemic. So even though the flu vaccination is not like COVID vaccination rate per se, but I think it's kind of reflect what agencies' policy regarding all types of vaccination. So I think it's kind of indicate the agency's effort and their policies to encourage the vaccination. So we are very happy to see the current the federal and local like authorities' effort to mandate the vaccination, COVID vaccination for the healthcare workers. And from my understanding, there's many home health agency embraced this mandate. But we also heard from some interviews with the agencies. They're still hesitating to implement this the mandate at their agency level because they're concerned about losing lose their the work their staff. So definitely there's a high correlation. I think hopefully after the pandemic, we hope we're going to see some change of flu vaccination rates.
Oh, yes. Well, vaccination is always on our minds, so we can't thank you enough for sharing this research and your information with us. It is incredibly informational and helpful. And we just thank you for sharing all that work with us.
Yeah, awesome. Thank you so much.
Thank you for inviting me.
Wow, Nikki, that was some great information from Dr. Shang.
Mm-hmm.
So next up, we're talking about an evaluation of an aerosolized hydrogen peroxide disinfection system for the reduction of Clostridioides difficile hospital infection rates over a 10-year period with research author Debra Runyan.
That was a mouthful.
I know. So Debra Runyan was the director of infection prevention at Pennsylvania Hospital in Philadelphia until her retirement in May of 2020. Congratulations, Debra. Pennsylvania Hospital, a nonprofit teaching 475-bed acute care institution, is part of Penn Medicine Health System. She now works per diem for the department. She has a medical technology Bachelor of Science degree from Nassau College and has been certified in infection prevention since 1995. She served as her local APIC chapter secretary from 2004 to 2005, as well as the membership chair from 2006 to 2007. She also served on Medline's advisory board from 2009 to 2010. In 2011, Debra received the APIC Hero of Infection Prevention designation for her work in implementation of a securement device for peripheral IVs. Fantastic. And also very excited to be talking to a fellow MedTech today.
I'm excited to talk about this project today.
Awesome. So thank you for joining us. And do you want to kick us off with a little background on your study?
So one of the things I wanted to make clear is that we started this study before there was the SIR benchmark. So we started back in 2011, and we're using the hospital-acquired infection definition. So it was difficult to write this paper because the benchmark started in 2014, so we didn't have a clear before and after the study to look at. So we were truly retrospective, looking at our data, seeing how we improved and what we did along the way to keep improving.
Well, Debra, infection preventionists have been focusing on C. diff for a while now, and a lot of new interventions have been introduced into the mix. So this goes along with what you were just talking about, the SIR changing along the way. And I wonder how controlled or monitored the variables were for the hospital involved in the retrospective study. So, for instance, the paper mentions that all rooms were cleaned with a 10% bleach solution daily and upon discharge prior to the AHP treatment. Was this protocol consistently used prior to and during implementation of AHP?
So actually, we began using bleach in 2009 when we had an outbreak of C. diff that we thought was related to cloth chairs being brought into patient rooms. And within a few months, we saw our rate skyrocket. So obviously, we got rid of the cloth chairs and we did a whole house clean and started to use bleach and continued with that process. There is a lot of variables. Throughout the study, we did room monitoring to see the cleanliness of our rooms using, at first, fluorescent gel and then switching to ATP. And that process, although we did it randomly throughout the study, wasn't consistently done. We could never link improving the cleanliness to the rooms to an increase or decrease in infections. But obviously, it is good to have clean rooms.
Mm-hmm. What about any changes in treatment, with vancomycin versus, and I can never say, is it metronidazole? I never can say that.
I'm not really that well versed in the antibiotic stewardship. I know that was going on behind the scenes the whole time, but I couldn't tell you a point in time where they did some remarkable change. That committee did report to infection prevention, and there was never a wow moment that we thought, oh, look at this really made a difference. Okay. The other thing, of course, every hospital is doing is hand hygiene and monitoring that. And again, increases in hand hygiene, while are good, it's very difficult to link them to infection rates. So this study, this fogging, was really the only thing that was a nice pairing to C. diff, that we could see when we fogged these rooms that the C. diff rate did decrease.
So you sort of answered one of the questions that had come to mind for me, which was, what did the hand hygiene rates look like? But in addition to that, I know that it's a recommendation that patients who are on precautions for C. diff, that the healthcare workers use soap and water. Was that also a policy?
Using soap and water when they left the room was a policy, but we never did a study monitoring that. A few times we would take it to monitor compliance with precautions. And to be honest, they weren't that good. It's a difficult thing to get at. So it was on the list if we really wanted to try to improve C. diff, to kind of go at that a bit, but we never did.
I'm also interested to hear if there was any data collected on how quickly patients were placed on isolation precautions, and if you did any data collection around appropriate use of personal protective equipment.
Again, we never really monitored the personal protective equipment use. We knew that was an opportunity to improve. In terms of, we felt that patients with diarrhea were being placed as soon as diarrhea started on precautions. Unfortunately, testing wasn't always done as quickly as placing them on precautions.
Yeah.
And when the definition changed and you couldn't use the acute onset date, i.e. the admission, as the start date, it put us at a bit of disadvantage.
Definitely.
I had to do a lot of education for the house staff around that.
So, Debra, do you know if PCR was ever used as the sole diagnostic at any point during the AHP study?
It was not. I actually went and looked all this up. So we used the EIA toxin until 2015. And from 2015 till 2017, we used GDH plus the EIA, and then used the NAT or the PCR for discrepancies. And It wasn't until 2008 that we switched to the NAT plus the EIA. And we did that because it was a system-wide decision to do that. So it wasn't just our hospital. Penn decided that that's how they wanted it done.
That's great. That's wonderful, because I know facilities who use or used PCR as the only diagnostic tool can have falsely inflated numbers of true C. diff infections. And so most of the facilities who have adopted a two-step algorithm, as you mentioned in the paper.
Right.
So I was just wondering if that was...
and it's my understanding that NHSN takes your testing methodology into account in calculating your SIR. So,
Yep.
Well, I thought that I was going to, your paper mentions that it's difficult to explain why the rates did not significantly drop between 15 and 16, but they dropped 60% from 2018 to 19. And
well, actually, he left 2017 out of that little bit of dialogue. So our cases dropped from 40 in 2016 to 27 in 2017. Great. And they remain low in 2018. So I think during that time, 2015 was the definition change. So we did a lot of house staff education. An algorithm was put in place about testing on patients that had laxatives, and to wait 24 hours before you did the C. diff test. So I think it just took a little while for all that to come together to start seeing a drop in cases. And the other thing is that we did decide to keep all of our positives, whether they were just PCR positive or toxin positive, in isolation. So I think that helped too. So everyone was isolated, which also meant that all those rooms were getting fogged. If we didn't isolate them, there'd be no way we could identify the rooms that needed to be fogged.
Great job on that reduction. What were some of the challenges to implementing the AHP protocol? I anticipate that leadership probably had some pushback due to the expense of the machine or machines, and probably the 2.5 hour room turnover time.
Well, this is true. It's always a challenge to make an argument to not only spend money but switch to a different technology. At the time, like the chair outbreak, we were having a little bit of an upturn in our rate due to the computers being placed in the rooms. And there had been no protocol in place on how to clean these computers. And although the electronic record initiative wasn't starting for a few months, people had started to use the computers. So we saw the increase in rate, again, sent out an alert. So that was one thing in our favor, sort of, because we had a challenge again to convince administration that this would be a good trial. And we were early adopters, so we were afforded the opportunity to trial the machines at first for 3 months, and then we got them to extend the trial to 6 months. So that was really helpful. And we expected the trial not to show a reduction in C. diff, but just to figure out how we were going to implement, because we also thought that the 2-hour time period was going to be a challenge. And as it turns out, because we weren't going to do a curtain change with the fogging, that we gained back an hour or so. So
that's amazing.
The curtain change seemed to be the deal breaker. It was saving $45 a curtain change, and it wasn't really 2 hours of time. It was more like an hour of time. So, but some of the other challenges were just getting EVS on board and having them be our partner, because obviously they're the staff that
Sure, they're the ones that have to be trained and prep the room and do the vent covering and all that stuff, yeah.
Right, and to manage the machines, where are they at, get them where they're going. So who is going to do that? Who is going to be in charge of these expensive machines? Who is going to be in charge of the reagent? So those things, we just needed time to figure out. The other challenge was to really identify what rooms were being fogged. So initially, they were fogging rooms like crazy, but they weren't the right rooms. So when we finally gathered up all these papers and took a look at it and matched them with C. diff patient, we said, whoa, whoa, whoa. And what we did is we put in an electronic system, a share drive, where they would mark it on the share drive, and then we could look at our C. diff patients, look at the transfers, look at the discharges, and make sure that the correct rooms were being fogged and give them immediate feedback. So every day I would email the person in charge and say, 100% compliance today, or you missed, room 325. And I think some of that, when a room was missed, they fogged it at the next opportunity. So it wasn't just let go. So I think that really helped in our success.
That's great, especially knowing that those C. diff spores can live in the environment for months. So, getting to the room eventually has its benefits no matter what, I would think. So I also found it interesting that while the turnover seemed to have doubled, that this didn't seem to be an issue with patient flow, which I totally would have expected otherwise. Can you tell us why you think that is? Do you have a lot of private rooms, a lot of double rooms?
At the time, no, we didn't. Most of our rooms were semi-private, but you have to realize, so when you go from having 75 cases to 40 cases even, that's less rooms that you have to turn over. So that's less time. So again, and thinking the 2 hours and start thinking of it in a time frame of just really an hour. And then what surprised us is the buy-in from nursing. Nursing really supported it and really liked the idea of the whole room disinfection. And they realized it just wasn't C. diff. It was, the other pathogens that were being eliminated as well. So they really liked that. And at some point, we started to fog rooms that were open. So if a unit closed for any reason over the holidays, they would go in and fog all the rooms. And nursing really just liked it. So they were the ones initially, when they weren't fogging the right rooms, kind of said, you don't think they're fogging the right rooms. So it was a surprise because we thought we were going to get more pushback than we actually did.
Awesome.
Do you have a sense of how many rooms per day required the treatment?
That's something I did at one point. Sometimes, now there's so few C. diff patients that there'd be maybe 3 or 4, and that's a high estimate. Sometimes there weren't any rooms that required it. One other thing that we did, if a C. diff patient happened to have to stay in the hospital for a prolonged period of time, for other medical reasons or because of their C. diff, we would change their room after 30 days and put them in a clean room and fog the room they had been in. Just feeling like it was good to give them a fresh start. That didn't happen too often, but it did happen a few times in critical care especially. If we did see a cluster in any particular unit in any given month, because we followed it pretty closely, we would give a shout out to the nurse manager and coordinate common area cleaning. So the nutrition room, the nurses' stations, make sure all the isolation carts were all wiped down with bleach. So that was another thing that we kind of kept took the pulse of.
That's fantastic. All of this is really great. What an amazing drop in C. diff over that period of time. We really appreciate you sharing your research with Nikki and I. Are there any takeaways for today that you want to send our listeners away with about your research?
We couldn't have done this without the support and the 100% buy-in from our EBS staff and administration. they own the machines, they operate the machines, they put a system in place to make sure that they got the C. differens. It was sort of like if they missed it from the sign, they had another alert system where they would know that this patient had C. diff and the room needed to be fogged. They were constantly in the beginning calling us with questions. So establishing that relationship was critical. And making the EVS staff aware that they were responsible for patient safety and instilling that pride in them. Even today, when we monitor for room cleaning, they're just so proud of themselves for doing this. And I'm very proud of them for doing that too. So.
Yeah, thank you. Thank you again, Deborah. We really appreciated having you on. Well, thank you for joining us today. We are Nikki Shore and Jessie Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection because, remember, infection prevention is everybody's business. To hear other AJIC podcast episodes and to access information about this podcast in the field of infection prevention and control, go to our website at AJIC, That's AJIC, scienceintopractice.org.
AJIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Research Committee and Pat Stone and Jean Brandt at AJIC and APIC staff, Lisa Tomlinson, Liz Garman, Bobby Gulshan, Chris Ruiz, Kelly Lynn Russell, Sylvia Quevedo, Kaylee Deaton, and Christine Miller. We work in partnership with Human Factor and audio tech Blake Alton.